Assalamualaikum warahmatullahi wabarakatuh. My name is Nur Izzati Athirah Binti Hamlizan. So today I am going to present image evaluation of food AP projection.
So first, let's start with the anatomy of the food. So here we have the bones of the foot and the radiograph of a foot. As you can see, the yellow color represents distal phalanges and hallux, and then the blue color represents middle phalanges from A to D. And then the green color are the proximal phalanges. The red color represents the metatarsal, specifically metatarsals 1 to 5. And then the orange color are the tarsal bones such as the navicular, cuboid, talus and calcaneus are also demonstrated. And lastly, pink color are the medial, intermediate and lateral cuneiform. Wait, I forgot to mention. So, according to Bone Ranger's textbook of radiographic positioning and related anatomy, the anatomy that should be demonstrated on foot radiograph are entire foot should be demonstrated, including all phalanges and metatarsals, navicula, cuneiforms and cuboids. Before we start, let's go through the positioning for the foot AP projection, because according to McQuillan, proper positioning ensures accurate visualization of joint spaces and bony alignment. First, patient is in a supine or seated position with plantar foot surface centered on the IR in an AP projection. Next, align the lower leg, ankle and foot keeping equal pressure applied across the plantar surface. Flex the knee until the foot is close to a 90-degree angle with the lower leg as possible. Align the CR perpendicular to the dorsal foot surface, placing a 10 to 15-degree proximal toward the calcaneus angle on the CR. Lastly, center the CR to the base of the third metatarsal. Next, I will introduce the true criteria used to evaluate whether the foot AP projection is correctly positioned. First criteria for true AP projection is the joint space between medial and intermediate cuneiforms is open. Next, 2 cm of calcaneus is seen without talar superimposition. Then, tarsometatarsal and navicular cuneiform joints are open. And lastly, bases of the first and second metatarsals are generally separated, but bases of the second to fifth metatarsals appears to overlap. Moving on, I will explain on how to detect rotation. First, assess the joint space between medial and intermediate cuneiforms. Space between the medial and intermediate cuneiforms should be open. If the joint space between the medial and intermediate cuneiform is closed, the foot is either medially or laterally rotated. To improve this, rotate the patient's foot laterally or medially until the pressure over the entire plantar surface is equal. Next, assess the calcaneus unsuperimposition with talus point. If more than 2 cm of calcaneal is demonstrated without talus superimposition, the foot is medially rotated. If less than 2 cm of calcaneal is demonstrated without talus superimposition, the foot is laterally rotated. To improve this, rotate patient's foot medially or laterally until the pressure over the entire plantar surface is equal. Lastly, to detect rotation, assess superimposition of second to fifth metatarsal bases, whether if it's decrease or increase. If metatarsal bases demonstrated decreased superimposition from second to fifth, the foot is medially rotated. If metatarsal bases demonstrated increased superimposition from second to fifth, the foot is laterally rotated. To improve this, rotate patient's foot medially or laterally until the pressure over the entire plantar surface is equal. Now, let's continue on how to detect incorrect CR angulation. To detect incorrect CR angulation, we can assess by looking at the tarsometatarsal and navicular cuneiform joints. If the tarsometatarsal and navicular cuneiform joints are closed, the CR was not aligned parallel with these joint spaces. To improve this, direct the CR to 10 to 15 degrees proximally towards the calcaneum until it is perpendicular to the dorsal surface. And according to Bone Ranger's textbook, less angulation is needed for patients with low longitudinal arches, whereas more angulation is required for patients with high arches. First, when using placement guideline, P is for projection and positioning. So this is a radiograph of AP projection of the foot. This is foot because of phalanges, metatarsals, navicular, cuneiforms and cuboid are included. Proximal calcaneus, talar neck and surrounding foot soft tissues are included. This is AP because third metatarsal is at the center of the radiograph because all 5 phalanges or metatarsals are seen next to each other. Now let's evaluate the positioning of this radiograph. The positioning for this projection is incorrect because the joint space between the middle and intermediate cuneiforms is closed when it should be open. The calcaneus demonstrate no talus superimposition when it should be approximately 2 cm of no superimposition with talus and calcaneus. And then the metatarsal bases demonstrate decreased superimposition. This means more pressure was placed on the patient's medial plantar surface than on the lateral surface, resulting in medial foot rotation. To improve this, rotate the foot laterally until the pressure over the entire plantar surface is equal. Next, let's look at the second example. The positioning for this projection is correct because the joint space between the medial and intermediate cuneiforms is open. Next, approximately 2 cm of calcaneus is seen without talus superimposition, so there is no improvement needed. Next, A in placement stands for alignment. First, for this radiograph, the alignment between X-ray tube and cassette is incorrect because the left side is larger than the right side. The alignment between X-ray tube and patient is correct because all sides are equal to each other. The alignment between cassette and patient is correct because all sides are equal to each other. The standard centering point is at the level of base of third metatarsal. The centering point for this radiograph is at the joint space between medial cuneiform and intermediate cuneiform. Next, I will show you another example for alignment evaluation. For this radiograph, the alignment between X-ray tube and cassette cannot be determined because there is no four borders of collimation. The alignment between X-ray tube and patient cannot be determined because there is no four borders of collimation. The alignment between cassette and patient is incorrect because right side is larger than the left side. The standard centering point is at the level of base of third metatarsal, and the centering point for this radiograph cannot be determined because there is no four borders of collimation. Next, C for collimation. So for superior part, there are phalanges, metatarsophalangeal joint, interphalangeal joint. For inferior, talus, calcaneum, navicular. For lateral, base of fifth metatarsal, cuboid, and medial cuneiform. So this radiograph has adequate collimation because the entire foot, including all phalanges and metatarsals and navicular, cuneiforms and cuboids, are seen within the radiograph, and there is no evidence of radiation protection apparatus seen on the radiograph. Next, E stands for exposure factor. So for epi-foot radiograph, to evaluate the radiographic contrast, we should look at the thin structure, which is the BCO of distal phalanges, and the thick structure, which is the BCO of navicular bone. Next, to evaluate the radiograph's detail and density, we should look at the thin structure, BTP of distal phalanges, and the thick structure, which is the BTP of navicular bone. Now, let's try evaluate exposure factor on a few radiographs. For this radiograph, the KVP used is too much for penetration and contrast. This is because the thin structure, which is the BCO of distal phalanges, cannot be seen, and the thick structure, which is the BCO of navicular bone, can be seen. And the MRS used is too much for detail and density. This is because the thin structure, which is the BTP of distal phalanges, cannot be seen, and the thick structure, which is the BTP of navicular bone, can be seen. To improve this, reduce the KVP by 15% and maintain the MRS. Next, the KVP used for this radiograph is inadequate for penetration and contrast. This is because the thick structure, which is the BCO of distal phalanges, can be seen, and the thick structure, which is the BCO of navicular bone, cannot be seen. And the MRS used is inadequate for detail and density. This is because the thin structure, which is the BTP of distal phalanges, can be seen, and the thick structure, which is the BTP of navicular bone, cannot be seen. To improve this, increase the KVP by 15% and maintain the MRS. For this radiograph, the KVP used is adequate for penetration and contrast. This is because the thin structure, which is the BCO of distal phalanges, can be seen, and the thick structure, which is the BCO of navicular bone, can be seen. And the MRS used is inadequate for detail and density. This is because the thin structure, which is the BTP of distal phalanges, can be seen, and the thick structure, which is the BTP of navicular bone, cannot be seen. To improve this, maintain the KVP and double the MRS. Lastly, for this radiograph, the KVB used is adequate for penetration and contrast. This is because the thin structure, which is the VCO of distal phalanges, and the thick structure, which is the VCO of navicular bone, can be seen, and the MS used is adequate for detail and density. This is because the thin and thick structure, which is the BTP of distal phalanges and BTP of navicular bone, can be seen, so no improvement needed. Next, M in placement stands for marker. So in this radiograph, as you can see, there is no evidence of anatomical markers since it used digital marker shown in the radiograph correctly placed and placed appropriately, not superimposing any region of interest. To improve this, use anatomical marker. Next, in this radiograph, there is evidence of anatomical marker shown in the radiograph correctly placed and placed appropriately, not superimposing any region of interest. A for aesthetic. The film size used for this radiograph is 24 cm 30 cm, sufficient to demonstrate all structures of interest. There is no evidence of artifact on the radiograph. For this radiograph, there is evidence of internal artifact on this radiograph. So since this artifact cannot be removed instantly, or sometimes the radiograph is taken for post-operative procedure, there is no improvement needed. On this radiograph, there is evidence of external artifact on this radiograph, and the artifact is a shoe. So since the artifact can be removed, to improve this, remove the artifact before the procedure. Lastly, N stands for name included on the radiograph. So as you can see on this radiograph, the patient's name and ID, date of examination and place of examination are not visualized on the radiograph. To improve this, put the patient name and ID, date of examination and place of examination clearly visualized in the appropriate area, not superimposed with structures of interest.
So for diagnostic acceptability, the accepted radiograph should have evidence of patient's information, evidence of anatomical marker, correct part and positioning, not cut off, no evidence of external artifact within the region of interest, correct exposure factor, and correct alignment. Whereas rejected radiograph can be resulted from missing patient's information, no evidence of anatomical marker, incorrect part and wrong positioning, image cut off, evidence of external artifact within region of interest, incorrect exposure factor, and incorrect alignment.